Well, I'd like to welcome everybody back, and let me just get my page in order. Good morning, or we're still morning. I'm Dr. Sandra Block. I'm professor at the Illinois College of Optometry, and I'm actually moderating this session that's focused on the future directions for improving access and care delivery. I'm going to introduce the panelists in just a minute, but I just wanted to kind of open up with a little bit of a defining statement just to kind of set our framework for the next section. Access really to vision care services is really concerned about individuals being able to seek and to receive the appropriate eye health and vision care services that they need. Access is really a very complex issue with multiple pieces that play into it. One of the things is, if services are really available, is there an adequate supply of providers? The extent to which a population is going to gain access to those services is also going to depend on a multitude of other things: financial, social, cultural barriers. We know that they all exist and actually will limit the utilization of the services that are even available. That actually is suggesting to us that access can be measured with affordability, physical accessibility, and acceptability of services, which we heard alluded to a little bit this morning in the media, but it also is the acceptability of services that are provided, and not merely that there's an adequate workforce. The availability of services along barriers to access must be considered in the context of differing perspectives, health needs, and material and cultural settings of diverse groups and societies. So actually, I'm picking up on the last comment we had at the end of the session. Now, I'm going to look to the speakers to address some of these things, but before we do that, I figured I'm going to be able to have an opportunity to share my personal perspectives on access. My day job is I work in Chicago, in the Chicago public school system, providing care to low-income individuals in schools that really don't access care appropriately. My second job, my night job, I suppose you can say, is working on improving access to people to eye care for people with intellectual and developmental disabilities. I feel very strongly that access is one of our core principles in almost every one of the recommendations that our report came out with. While it may not directly say so, it only really does in the fifth and the sixth recommendation. Access really is focused in on every one of the recommendations to some degree. So I'm going to start by introducing our first speaker. And our first speaker is Dr. Paul Lee, who is an F. Bruce Freilich Professor of Ophthalmology, Director of the Kellogg Eye Center, and Chair of the Department of Ophthalmology and Vision Sciences at the University of Michigan. He's a glaucoma specialist and an active clinician, surgeon, and educator. He's published over 200 articles on glaucoma and eye care delivery in general, particularly on understanding and improving eye care. Dr. Lee's been the PI on numerous research projects evaluating appropriateness of cataract surgery, process quality of glaucoma and diabetic retinopathy care, utilization of patterns of eye care, provider workforce analysis for ophthalmology and orthopedics, and analysis of failure patterns for the treatment of diabetes-related eye disease and glaucoma. Okay, Dr. Lee, I welcome you to the podium.
Thank you very much, and thank you, and thanks to the panel and the National Academies for putting on this wonderful symposium. Before I get started, I do have the privilege of working with many organizations, many of which are represented in this room. Today's presentation just reflects my personal opinions and not that of any of these organizations, especially those highlighted in red. The National Academies panel should be congratulated for doing a marvelous job of organizing the field, of putting together some terrific recommendations and a pathway forward. And there were 5 major clusters of recommendations, and we're speaking right now on expanding access to appropriate clinical care in order to achieve our goal of helping people see across the United States. And this talk will focus on 2 specific portions. One is, what can we pull from the National Academies report about an integrated care system, and I emphasize system, that will allow us to achieve our goal of a public health perspective and approach to improving vision. And then what are some existing examples of elements of this that we might all learn from? So one of the first themes in the report that I agree with is this need to have a continuous improvement system. It really is a system that integrates all of the different elements. We all have different levels of examples and experience with this, but really having an integrated system is important. The second is really there is a need for evidence-based unified guidelines to reduce variation and drive payment policies. The literature is replete with evidence of significant variation in care across every disease, across preventive services and vision. And this is just one example. Even after the spread of evidence from the cataract report of the 1990s about the lack of evidence and really subsequent analysis showing really no basis for requiring significant preoperative testing for cataract surgery in the vast majority of people, that we still have significant variation in that, as well as in the variation in the use of preoperative ophthalmic testing prior to cataract surgery and other surgery. And so having evidence base that drives payment policy will help change some of these practice patterns. The third is the need to integrate care across the healthcare delivery system. On the left, you see a more traditional model of care, and on the right, you begin to see some variants of the way that care is being increasingly organized and will need to be further organized within the traditional healthcare delivery system. This is from a paper talk about primary care, but again, you can see how the care is shifting to more of an integrated system where you have the patients, their families, mobile apps, wireless technology, and different ways of bringing people together with the social support system. We had a great comment about the importance of understanding communities and where people come from in terms of cultural context. Well, the social support system is critical to so much of what we do. We know from the Framingham data that if you want to lose weight or stop smoking, if you associate with people who are losing weight and don't smoke, you have a much better chance of doing the appropriate healthy behaviors. Another key piece is to think more broadly outside of the healthcare system to the public health systems and to be able to use data. And so there are a lot of partners that we could work with in this space. It's not just the healthcare providers, but we saw some good presentations about schools, about public health departments, social welfare departments. In this room and on this panel, you have representatives of people from non-governmental organizations that are really invested in this. And as our Dr. Ye pointed out, really having a market-based solution for a sustainable approach is really important to be able to accomplish this. And on the left, you can see where evidence can help us focus efforts on childhood amblyopia and strabismus, vision loss in children. The areas highlighted in blue are actually areas where there's a significant underdiagnosis compared to expected rates of amblyopia and strabismus using claims data. And so now we know these are the areas that we can focus in on with the public health departments in these specific counties to really hit the most vulnerable people. And then it's really important to enhance the diversity of our workforce going forward. This is data from Roy Wilson's nice work that was just published recently, showed relatively flat rates of work in terms of the workforce and ophthalmologists entering ophthalmology as a field. And so as our country becomes more diverse, we need to have a workforce that reflects our population as well as the need for the appreciation of the cultural and other diversity that exists in our country. So what can we learn from systems that are currently doing things like this? Well, one is, let's not look at all the usual places. So our colleagues at LV Prasad have done an amazing job of creating an integrated eye care system that involves the community with people that have certain levels of training, and as you move up the pyramid, there's higher levels of training, higher levels of expertise. It brings in cultural alignment, it brings in people who are trusted at the local setting. Dr. Rao founded LV Prasad. This is a great paper in eye for the Barry Jones Lecture out of Moorfields. I'd recommend that people look this up and read this in detail. Another place to look are some of our colleagues in the VA system. The VA has been a leader in integrated eye care for many decades, And at the Emory VA, there's now a system, again, you can see that pyramid, where one of our colleagues is working with ophthalmic technicians at community-based offices to provide eye care services through telemedicine and protocols. Again, a really worthwhile paper to pull if you haven't seen this already. Our folks at Kaiser and other integrated healthcare systems are beginning to experiment with ways of taking care of patients that doesn't require inpatient examinations. The second concept is to move care away from healthcare facilities to the community and the home. Dr. Hyman will be talking about the WILS effort coming up as a CDC effort. And we have a container with a community health clinic in Jamaica that becomes a nidus point for the community. And then we all get emails from patients that says, hey, can you just take a look at this? This bypasses the need for a healthcare facility. Third is to leverage the new technology that's available. These are examples from the Aravind Eye Center Hospital in India. Again, another leader in the world in terms of innovations. They do probably this year, over 400,000 cataract surgeries in their system. They're very efficient with safety rates as good as the US and better than the UK. And they also have a telemedicine system using technicians linked back to home. Big data will help us create more accurate diagnostics for use for anyone using an image-based system. This is an example of diabetic retinopathy. The fourth element is really to begin to talk about the social determinants of health. We talked about the zip code being as important as the genetic code, the lifestyle, the opportunities, the availability of services that really have an impact on health is important. And finally, this need for integrated data analytics across stakeholders. And the registry that you heard about, the MORE and the Academy IRIS registry, is really fundamental to what we want to do to begin to improve the care we have and then to begin to link with our colleagues in other fields. So thank you very much for the opportunity to be with you.